condition which is both extremely important because of the problems that it causes to people who have it, but also surprisingly neglected. And I'm particularly excited to have two amazing speakers here today, starting with Dr. Georgina Krebs, who is a recently appointed Associate Professor of Clinical Psychology here at UCL, and really the expert at the moment in BDD and its treatment, who's going to present some very exciting new data, I've heard. And then we have our other great speaker I'm going to introduce later on. Dr. Krebs, would you like to start, please?
Thank you for the introduction. I will just try and share my slides. Hopefully you can see that okay? Yeah.
Yes.
Great. Sorry, just having a few technical problems at my end. All right. Well, thank you so much for the introduction. It's a real pleasure to be able to talk today about body dysmorphic disorder in this Catalyst seminar. So I'm going to be talking about the epidemiology of body dysmorphic disorder in young people. And I'll be presenting results of a study. Sorry, my slides don't seem to be moving on. Okay, here we go. I'll be presenting results of a study which is a collaboration with Professor Stringaris, but also Professor Tamsin Ford at the University of Cambridge and Dr. Bruce Clark at the Maudsley Hospital. And this study and all the planned analyses were pre-registered on Open Science Framework. So if you're interested in reading more, you can have a look there. So I thought I'd start with a little bit of background about BDD. So BDD, body dysmorphic disorder, is characterized by a preoccupation with perceived flaws in appearance. And most commonly, people with BDD worry about aspects of their face, so facial features such as their nose or skin or eyes. But the concerns can really relate to any body part, and often there are multiple appearance concerns. And I think what's really striking in BDD is that these perceived flaws appear as very, very minor, or more usually, they're completely unobservable to other people. So we don't see what the person with BDD sees when they look in the mirror. But nevertheless, these appearance concerns are, of course, a source of great distress and suffering to the person with BDD. And often to cope with this, people with BDD become highly avoidant, for example, of social situations, and they engage in time-consuming, repetitive behaviors that are often aimed at checking their appearance, covering up or concealing their perceived flaws, and also trying to correct their perceived flaws. So BDD was once thought to be a very rare condition, but over the last 15 years, there have been 3 epidemiological studies in adults. 2 of these were in Germany and 1 was in the US. And these have looked at the prevalence of BDD among adults in the general population. And they indicate a point prevalence of about 2%. So it seems that BDD isn't rare. And in fact, it's possibly more common than some other closely related conditions like OCD, obsessive compulsive disorder, and anorexia nervosa. And we also know that BDD typically develops during adolescence. About 70% of adults with BDD retrospectively report that their difficulties emerged before the age of 18. And although the current evidence is fairly limited, it suggests that BDD tends to persist in the absence of effective treatment. So it's a chronic condition. And I think this is really important to hold in mind when we're talking about BDD in young people, because we're not talking about a normal adolescent phase or normal adolescent self-consciousness, some sort of developmental phase that people will outgrow. This is a chronic condition, and it's associated with really high levels of impairment. At least in clinical samples, there are good descriptions of the impairment, and we see that a high proportion of young people are out of school, for example, and also high rates of suicidality are very notable. So despite being quite common and a serious condition, it's really striking that it's been under-researched, as Professor Stringaris mentioned at the beginning. So some of you will be familiar with this, but a few years ago, the charity MQ and the Wellcome Trust conducted a review of all mental health research funding in the UK. This figure shows funding over a 5-year period. And you can see that obsessive compulsive and related disorders, which includes BDD, receive less funding than any other diagnostic category. So it's that tiny grey sliver that represents less than 1% of the total research funding. And of course, what this means is that many of the most basic, most fundamental questions about BDD we don't have answers to yet. And that's particularly the case in young people. So for example, we know very little about the epidemiology of BDD in young people. There have been a really small number of studies that have looked at the prevalence of BDD in community samples in young people. The majority of these have been conducted in schools, and they've found prevalence estimates ranging between 1.7 and 3.6%. The largest community-based prevalence study of BDD in young people that's been conducted so far was actually carried out with a Swedish twin cohort. And this found a prevalence of 1% in 15-year-olds and 2% in 18-year-olds. So together, these again suggest that BDD is relatively common, and these estimates mirror what we've seen in adult epidemiological studies. But there are some important limitations that should be considered. So first of all, these studies are based on either convenient samples or specialist research samples, and they may well not be representative of the general population from which they were drawn. But I think also very important to note that all of these studies relied on really quite brief self-report questionnaires of BDD, and they used cutoffs that had been validated in adults but not in young people. So whether these findings translate to diagnosable BDD is unclear. And lastly, none of these studies included children. They've all focused on adolescents, so we really know very little about BDD in children. So the current study aimed to address some of these gaps in our knowledge. And we had 3 main aims. The first was to understand the prevalence of BDD in children and adolescents. And we wanted to test the hypothesis that BDD would be more common in adolescents and also more common among girls. We also wanted to examine patterns of comorbidity and look at the association of BDD with psychosocial impairment and suicidality. So for the study, we used data that was collected as part of the Mental Health of Children and Young People in England survey. And this was a survey that was conducted in 2017 by the Office for National Statistics and the National Centre for Social Research. It was commissioned by NHS Digital. And what's really important is that this survey was administered to a stratified probability sample of children and young people from across England. So the sample was drawn from GP registers and using random probability sampling within 380 postcode sectors, young people were identified and approached. So the total sample for this study was about 9,000 young people, and they were aged between 2 and 19 years of age. I'll go on to talk about the sample that we analysed, but essentially BDD data was only collected for those aged 5 to 19. So 2 of the measures that I'm going to mention that we used in our analyses were the Development and Wellbeing Assessment, the DORBA, and the Strengths and Difficulties Questionnaire, or SDQ. So the Development and Wellbeing Assessment, I'm sure some of you are familiar with, but it's a diagnostic assessment tool. There's an online version, but in this survey, it was administered as a face-to-face interview. So researchers interviewed all parents and young people who were aged 11 and older. And the DORBA assesses for all common DSM-5 psychiatric disorders. Each diagnostic category starts with some screening items, and if they're endorsed, they're followed by a more detailed assessment. So for example, the BDD module includes 24 closed questions and several open questions. So it's really quite a comprehensive assessment. And what's very important to note in this study is that the responses were then reviewed by a trained clinician who assigned the final diagnoses. So they collated the information from parents, from young people, considered differential diagnoses, and using clinical judgments, assigned the final diagnoses. The Strengths and Difficulties questionnaire, I'm sure you're all very familiar with, so I'm not going to talk about that in detail, but there are the 5 symptom subscales listed in the first bullet point, and also the impact scale, which measures psychosocial impairment. So just to mention that the analyses were conducted in R using the SurveyR package, which enables us to include the sampling weights. So the estimates that I'm presenting are weighted estimates. So the current sample the sample that we analysed, as I mentioned, we focused only on those aged 5 to 19 because they were the people with BDD data available. This comprised a total sample of 7,654 young people, half female, half male, with a mean age of 11. And the ethnic composition of this group was really representative of the general population in England. So in terms of the results, there were 63 cases of BDD identified, which translates to a weighted prevalence of 1% for BDD. But we saw really quite large effects of age, as we'd expected. So you can see here that the prevalence of BDD was much higher among adolescents, nearly 2%, compared to children, where it was really quite rare. And this effect was significant. And similarly, as expected, we found a sex effect. So the prevalence of BDD was higher among girls compared to boys. And again, this was significant. When we looked at the interaction, you can see a sort of pattern that suggests that BDD increases with age to BDD prevalence increases with age to a greater extent in girls. There's this big jump from childhood to adolescence compared to boys. But this interaction effect was not significant. This may well reflect the limited statistical power, which I'll come back to later. In terms of comorbidity, comorbidity was very common in the BDD samples. So 70% of the BDD cases met diagnostic criteria for at least one additional disorder. Very common among these were internalizing disorders, so particularly anxiety disorders, which were seen in 60% of, almost 60% of BDD cases, and depressive disorders, which were seen in about 1/3 of the BDD cases. But interestingly, externalizing disorders were also quite common, with 1 in 5 young people with BDD meeting criteria for an externalizing disorder. So we also looked at comorbidity by looking at the symptom subscales of the SDQ. We ran linear regression models to test the association of BDD with these symptom subscales. Apologies that this is a bit overly colourful, but what you can see in the top 5, the top half of this figure are the unadjusted associations. So these are the crude associations between BDD and the symptom subscales. And in the bottom half, you see the adjusted associations where we adjusted for age and sex, which could confound the relationship. And what you see is that BDD is significantly associated with all of these forms of psychopathology, even after adjusting for age and sex, with the exception of the prosocial behavior subscale. And prosocial behavior captures qualities like caring about other people's feelings, being kind, helping out, and it's highly correlated with autism spectrum disorder traits. So we're not seeing an association there. And I should have mentioned that this is self-reported SDQ symptoms. We replicated these analyses with parent-reported symptoms. So these are parents reporting on their child's symptoms, and we see a very similar pattern of results. So our last aim was to look at the association of BDD with impairment. So first we looked at the SDQ impact subscale, and this figure shows the again the results of linear regression models. So this time the top 3 bars, the green bars, shows self-reported impact, and the bottom 3 bars, the purple bars, show parent-reported impact. So if we look first of all at the top 3 bars, the green bars, you can see that in the unadjusted models, BDD was associated with significantly associated with impairments. This remains significant when we adjusted for age and sex in a partially adjusted model. And in our fully adjusted model, we additionally included all comorbidity, and the association of BDD with psychosocial impairment remains significant. We then, if you look at the purple bars, you can see that the pattern of results is similar, but the fully adjusted model was not significant. So we also looked at BDD and suicidality, because that's something that's been focused on a lot in the previous literature, that BDD is associated with high risk. So just the caveat here is that I'm using suicidality as a shorthand, and in fact this variable captures lifetime self-harm and suicide attempts. So among the young people with BDD, 45% reported a lifetime history of self-harm and suicide attempts. And this figure shows the results of logistic regression models. So again, we've got the self-reported suicidality in the green bars, and the parent-reported suicidality in the purple bars. And we have the unadjusted, partially adjusted, and fully adjusted models. And so what you can see is that BDD is significantly associated with suicidality in the unadjusted models. When we control for age and sex, it remains significant, but when we additionally adjust for comorbidity, the effect is no longer significant. And this might suggest that suicidality in BDD is largely accounted for by co-occurring conditions like depression. It may also be a power issue. And so one of the next steps that we're taking, which we'd planned in our analyses, is to replicate all of these analyses looking at appearance concerns, so people who don't meet threshold for BDD but do report appearance concerns, because that's obviously a much larger group and gives us greater statistical power to detect these effects. So just some preliminary conclusions. I think these data really reinforce that BDD is relatively common, especially in adolescent girls, where the prevalence is estimated at 3.4%. But we know that BDD often goes undiagnosed. And so there's clearly a real need to improve detection and diagnosis. Most people with BDD won't spontaneously disclose their concerns, but if they're asked, they will be open about it. So previous research we've done has shown that 95% of people with BDD will endorse a simple screening item that asks about appearance concerns. We've also shown high rates of comorbidity. So I think it's really important that clinicians working with BDD are mindful of this, that they're assessing for comorbidity and factoring it into treatment and care planning. And also holding in mind that comorbidity or the comorbid problems are often the presenting problem. So again, people with BDD will often present to services talking about their depression or talking about their social anxiety, and not mention their BDD unless directly asked. So I think that's also really important for clinicians to hold in mind. And lastly, we've seen that BDD is associated with significant impairment, and this is independent of comorbidity. So it's an impairing condition in its own right, and it's associated with high levels of self-harm and suicidality. So I think this really underscores the importance of improving access to evidence-based treatment for young people with BDD, and also to be mindful of risk assessment and to have sort of dynamic and ongoing risk assessment as part of the clinical care plan. So I think I'm going to stop there because I've definitely used up my time. I hope I haven't run over too much, but thank you very much. And I think Argyris will tell us what to do about questions.
Yes, thank you. Thank you very, very much. So two things. First of all, are there any technical, purely technical questions? Content questions we're going to discuss later. I don't see any in the chat. No one has come up with technical questions. Okay, now there's it's an embarrassing moment for me because in my anxiety as chair, and those of you who have been chairs will know that, those who haven't, and will be in the future, will know what I'm talking about. I've forgotten the most important thing about this talk, namely that we have Ms. Kelly Boone and Avella Boone here, who are a family with lived experience with BDD. And this is both a great honor for us, but also very, very helpful actually, so that we can actually hear things from people who know what they're really talking about by first-hand experience. So I want to welcome you both here very much. As we've discussed before we started here, you're gonna have the time at the end to conclude things. So we're very much looking forward to that. So I want to ask everybody to warmly welcome Kelly and Avella. Thank you. Now, our next speaker is Dr. Amy Harrison, who's an associate professor at UCL, at the Institute of Education, who's doing some very important work on BDD and its interface with eating problems as well. Amy, thank you very much for joining us, and we look forward to your talk.
Thank you very much. I'll just get my slides up for you. Okay, hopefully that's working. Hi everyone, so I'm a clinical psychologist and I've also done lots of research in the field of eating disorders and some research around BDD. So I thought what I might try and speak to you about today, to really complement what Georgina's already shared around the epidemiology of BDD, is to speak about how some of the symptoms and challenges people with BDD experience might be similar to those that people with eating disorders experience. And to really think together with you about when is the sort of dysmorphic part of an eating disorder, so the way that people might experience their body, when is it something about the eating disorder itself, so concerns about weight and shape, and when is it a true comorbidity, when is it actually BDD and needs its own treatment and own kind of focus. And then finally, to be thinking with you about what we know from the research evidence and how we might be able to use this to support people experiencing these challenges and concerns. So I guess I've always worked in eating disorders all throughout my career. And one of the things that's really struck me about the people that I've supported and the research that I've done in the field is that eating disorders, they do overlap with lots of things. So some people have conceptualized them as sort of anxiety problems. Others have thought about them as kind of mood problems. Some people have suggested that there may be a form of obsessive compulsive disorder. So as a field, and I'm always sort of complaining about how much research funding we get, and I feel terrible that we're only the sort of second worst, poor BDD down there. But as a field, we're often working with people and researching a phenomenon that has lots of overlapping and shared challenges, and that's a sort of bigger picture of psychiatry. There are lots of sort of transdiagnostic features. There was a really helpful review in 2013 that looked at the sort of clinical and personality characteristics of people with an eating disorder called anorexia nervosa and body dysmorphic disorder. And I guess it's important to point out that there are lots of different types of eating disorder, and a lot of the research around BDD has been conducted in the context of people experiencing anorexia. So this is where people are sort of under eating, they will likely have a very low body weight, and they'll be very distressed about their weight and shape, and their self-evaluation will be unduly influenced by how they feel about their shape and weight. And we can see here some of the shared challenges. Diagrams. I think there is quite a bit of overlap. So both of these difficulties involved appearance-related concerns. As Georgina's kindly pointed out already, BDD, like anorexia nervosa, is also associated with difficulties or delays in seeking treatment. Both of these difficulties can have a kind of relapsing and remitting course. And, you know, that's people's experiences will really differ. But for many people, they'll experience an episode of the illness and they might sort of get a bit better, and then under times of stress it can sort of flare up again. Anorexia nervosa and BDD are also both associated with low quality of life, and just like in BDD, people start experiencing these symptoms in adolescence. We know that a common time of onset for anorexia nervosa is also during adolescence, although people can develop eating disorders at any time in their life. This is quite a common time. Unfortunately, eating disorders are often spoken about as an illness that can be difficult to overcome, that present real, you know, the illness itself presents real challenges for families, loved ones, and kind of professional supporters, clinicians that are trying to help. And not everybody overcomes this difficulty. And I think that's another shared challenge that's mirrored in the BDD literature. And sort of thinking about the sort of underlying etiology, the causes of perhaps an eating disorder like anorexia nervosa and body dysmorphic disorder, studies have actually shown that there might be shared differences in the way people are processing visual spatial information, in the way their brain is processing and reacting to different stimuli, which might actually explain some of the problems that people experience in evaluating and making sense of their body or particular parts of their body. And one very notable type of BDD symptom that we see a lot in eating disorders is perhaps something that's called muscle dysmorphia. And this is where people are experiencing very significant body image disturbances, but sort of in the reverse direction to anorexia nervosa. So often people with anorexia will feel that their body is too big, or the shape isn't right, or both. And people that experience this muscle dysmorphia really idealize muscularity. So they might feel that their muscles are not well enough developed and might be very focused on this, and it might cause them a lot of distress and interference in their life. And this is something that we, I guess, in eating disorders see quite a bit, and we sort of see it a bit more regularly in males with eating disorders. Although not, you know, other genders can experience this, but it is something that is a bit more common in males with eating disorders. So again, there's an interesting and important overlap there. One of the really key symptoms that BDD and eating disorders share is this idea of how people are responding to the distress that they're experiencing about a perceived flaw or defect or actual flaw or defect on their body and their body weight and shape, perhaps in the context of an eating disorder. And this is what we call body checking. And there's a very useful review that was conducted a couple of years ago, and you can actually see how widely this has been studied. So there was over 50 studies that had looked at this in eating disorders. And this symptom that's very key in BDD is also present in people with eating disorders. I would caution that unfortunately the meta-analytic part of this review, the studies that were included there that were sort of eligible to be analysed in this way, pulled together, did only include women. But overall, this group was checking their body significantly more and avoiding their body or parts of their body significantly more frequently than people without eating disorders. And usefully, this review covered lots of different types of eating disorders. So it had anorexia nervosa, bulimia nervosa, binge eating disorder, and other types of eating disorders that don't meet the diagnostic criteria for those ones. And the finding did not vary by eating disorder subtype. So I think that's really important and useful. And I think we can really share knowledge and skills around how to help people experiencing these difficulties between our fields. And this study here looked at whether treatment could help with body checking. And what it found was that when people went into treatment for their eating disorder, after treatment and at follow-up, they were actually able to check their body less. So feeling differently about their self-evaluation, their self-esteem, having ways of eating regularly and looking after their nutritional health made them perhaps less disturbed about their body, and therefore they were needing to check it less often. You know, a really common example would be somebody with an eating disorder who perhaps eats something and then is drawn to the details of their body. Some people I've worked with have said to me they can feel their body expanding and it feels like it's changing from eating a small snack. And they can become really attuned to cues and triggers that they feel, that they perceive in their body. And we've often thought that that's perhaps because people are really good at details. Often people with eating disorders are good at spotting small changes and details. And that might be part of it. And part of it is probably because it's causing them distress. And understandably, they're wanting to do something about that and check and see if their body's changed in a way that would be really awful for that person. And the people that were able to improve the amount of body checking that they did actually showed improvements in their overall mental health. So I think that's a really useful piece of information from this work. So far we've thought about some of the sort of overlapping symptoms, some of the overlaps between BDD and eating disorders. And we know that checking of one's body is important in both difficulties. And we know that people will have very high distress and concern about either their whole body weight and shape or a particular part of their body. And what we often see in eating disorders is people will be distressed by certain parts, but there might be multiple parts. So they might say, I'm not keen on my stomach and my legs. And that's perhaps a little bit different to BDD, where the focus of the perceived or actual defect or flaw is a very, commonly a very specific part of the body and commonly on the face, as Georgina's pointed out. So there may be cases, there may be examples of where people are distressed about their overall weight and shape, and bad luck, they also have a comorbid body dysmorphic disorder in the context of their eating disorder. And this again is something that we have got quite a bit of prevalence data on. So we can see here there's a number of studies that have looked at how often BDD is co-occurring alongside an eating disorder. Most of them actually have looked at anorexia nervosa, but as you can see, the last one looked at different types of eating disorders. We're looking at around sort of a quarter to a third-ish of people with eating disorders also having a separate diagnosis of BDD that of course warrants its own treatment and understanding, and may not disappear when a person overcomes their eating disorder difficulties. So that's an important, important point to raise. If this is a sort of separate illness, it probably won't resolve. Certainly that's been my experience as well in working with people with eating disorders, when the eating disorder itself goes, because it has a slightly different function. It sort of can affect the person in a slightly different way. One of the really good news messages from the literature is that we can actually do something about how people feel about their body. And I've worked quite a lot with people who have had eating disorders that have needed them to be treated in hospital. And that's quite an interesting experience, because you often, are sort of helping a person in a very acute phase of the illness to restore their nutritional health, kind of support them out of a very acute crisis. But we know that when we work with people in a more outpatient setting, where we're not, people's medical status is in a different place, and they're really at a different stage in their recovery, we can do a lot to support people's body image concerns and distress. So there was a review that was conducted in 2019, which actually looked at eating disorder treatments, which had used CBT informed approaches. So not just CBT, actually, it was what they call third wave treatment. So it might be things like mindfulness-based treatments, acceptance and commitment therapy, dialectical behavior therapy, which actually had the largest impact, interestingly, on body image concerns in people with eating disorders. And maybe that, this is a treatment that really focuses on people's ability to regulate their emotions and to really care for their emotional health. So perhaps there's an important role for these skills here. And these treatments actually did help people with their body image concerns. So as a field, we do have some useful ways of tackling people's body image distress. And some studies show that these improvements are lasting when we follow people up. They're still feeling good enough about their body image. That's something we often talk about in treatment. That we're not going for sort of an ideal, a perfect body image. Good enough body image is what we're after. And how might eating disorders and body dysmorphic disorder be different? Well, I think I've already alluded to this. I think one of the key things that we know from clinical work is that people with eating disorders will be dissatisfied about their overall weight and shape. So their concerns about their body image and their distress will be more global. And they may have dysmorphia in relation to parts of their body. They may think a part's too big or too small, or got some sort of defect related to it. And the distress may hone down on certain areas. But unlike in BDD, it won't be specifically focused on a very particular feature. So I think that's a really good way of kind of useful way of thinking about where the differences are, whether it's more about an eating disorder, or is it more about is it more of a body dysmorphic disorder? As we've seen, there's lots of overlap, there's lots of similarities, but I think this is a useful way to look at one of the key differences. There has also been research into these differences, these potential differences. And we've heard that depression is very important in body dysmorphic disorder, and it may be also even more significant in eating disorders like anorexia nervosa. And studies have also looked at concepts like how closely tied to reality, to an objective reality, people's concerns about their body shape, or the sort of maybe even a drive for thinness are. And measures have called this sort of delusionality. And it does seem to be specifically related to the concern with body shape and a drive for thinness in those with anorexia nervosa, and significantly associated with body BDD symptom severity in those with BDD. So it might be that some of the same treatments are actually useful here. Some authors in the field have spoken about anorexia, particularly type of eating disorder, and BDD may be more appropriately classified as kind of body image disorders, and it'd be useful to talk about this together, about whether others think that's useful or helpful or interesting, or might be superfluous. I'm not sure. Perhaps we'll have a bit of a chat about this later. But they may actually benefit from quite similar therapeutic approaches that really target these underlying disturbances, differences, difficulties, distress. And I think the other thing that I'm really conscious of in my work with people with eating disorders is that a lot of the intervention is about helping people to gradually expose, well, not gradually, but to expose themselves to feared outcomes. So for example, if you're working maybe using a CBT-based treatment in anorexia nervosa, you will be helping them to try and eat regularly to meet their body's nutritional needs and help their health, and really helping people to test out what happens there when they expose themselves to a really feared outcome, that their weight might shoot up by kilograms and kilograms, and you know that would be in the end of the world for some people. It'll be incredibly distressing. Does that actually happen? So it's a bit of a behavior experiment, but also can I cope if my weight changes? And I think that a lot of the in CBT for BDD, that exposure element, that behavioural experiment component is also really important. So there are perhaps similar ways of helping people out of these difficulties, where we can share knowledge and experience across. And they, you know, the idea is that perhaps if they are that similar, they will be responding to the same sorts of support. Now, there is always problems in the research evidence, aren't there? So a couple of caveats and cautions. A lot of this work is sort of related to the overlap between BDD and anorexia nervosa as an eating disorder. But we know that there are also very significant body image concerns in other eating disorders like bulimia nervosa. In fact, that's part of the diagnostic criteria for this illness, that people's self-evaluation is unduly influenced by how they feel about their weight and shape. And there hasn't been a huge amount of research in this group. And I think that's actually a very interesting group to research, in the sense that people with bulimia nervosa can often represent lots of different weights and shapes. And so I think this can be a more diverse group, and I think there's lots to learn. Also, I think a problem that Georgina has pointed out prior to her study is that a lot of this work has come from adult populations and from female samples. So we need to know quite a bit more about the overlap and comorbidity and treatment pathways for people with eating disorders and or BDD or symptoms of BDD in other genders and across the age spectrum. So what does this tell us about what to do? I think mirroring what Georgina suggested about making sure you ask about BDD being really important. I think we've got that in eating disorders too, that we really need to be better at asking about these symptoms and understanding about whether, you know, that a person might be experiencing BDD as well as an eating disorder or might have significant symptoms of BDD, and to be asking much more about this in clinical assessments. We're very good at asking about how people feel about their weight and shape in general, and we can also ask much more. I think, you know, that involves, of course, really listening to the person that you're supporting and understanding more about their experience and how their relationship with their appearance and their body has changed over time, and then working together with them to develop a really good roadmap of how their distress and their concerns have developed and what might be keeping them stuck. And then that will give you a good clue about what to do next. I think the other thing we need to think very carefully and sensitively about, particularly in people that have eating disorders where there's low weight, is that if we want to support people with feeling different about their body image and reducing their body checking, reducing their body image concerns, reducing any dysmorphia, you know, the evidence base suggests that that involves an element of exposure work. So being able to look at their body, not avoid it, being able to care for it and see it as a whole, rather than focusing down on specific parts that they may be distressed about. And we've got to be careful about doing that when people are dangerously underweight. I mean, that wouldn't really be the thing we would be doing at the time, because we want to be making sure that their, you know, their health status improves. But really helping them to do that across the course of their recovery. And it's something that patients often tell us, that I feel really upset about my body image. I feel really upset about how I look and my body. And their body is changing a lot. You know, if they're changing their weight, if they're improving their nutritional health, their body will change. And I think as a field, we have to be much more mindful of that, and more transparent with people, that recovery will involve changes to people's body weight and shape. I think that's my final slide. Yeah. Thank you.
Thank you so much, Dr. Harrison. Thank you, Amy. This is really, really fantastic. I think that Kelly and Avella, before we start with the questions, it would be wonderful if you had any thoughts that you would like to share with us, comments, and anything really you would want to tell us.
Anything you had to say? I just wanted to say that as somebody with body dysmorphia and who's recovering from body dysmorphia, and I also have a friend who has anorexia nervosa, I think what you were saying about exposure work is very important. I'd say exposure work has helped me quite a lot in the past, with reducing my makeup and wearing clothes that actually fit me and things like that. Yeah. Anything you want to say?
Yeah, I just wanted to add that the patient has to be in a certain frame of mind, or it has to be able to receive the CBT given to them. Avella had 60 CBT for BDD sessions with the amazing Emma Baldock, She wasn't able to fully take in that advice and to do the exposure work, because she actually wasn't on the correct amount of medication during that time. And it wasn't until that she went under the Maudsley umbrella and they sorted out her medication and really explained to her, this was the crux of it, they explained to her that it was a 6-month process once she was up at the maximum dose of her SSRI before she would possibly begin to see the benefit of being up at that very high dose. She was also put on to aripiprazole during that time as well to really augment the SSRI. And that's really when change began to happen for her after being ill from the age of 11. She was 16 by this point and had missed, her GCSEs, missed school, had been completely isolated. It wasn't until she was medicated properly and for a sustained time that she was able to put that amazing CBT to use. And by the time then her treatment started at the Maudsley, she was had already wiped her makeup off and was already willing to push it further with her clothing and just to be able to take that next step in her life. So it's all very well kind of it's getting the person in the right place to start the CBT that's massively important.
I just wanted to say going off what my mum's saying about medication, there's a lot of false information about SSRIs. I know a lot of people who think it's artificial serotonin, just like things like that, and to be explained properly what it actually does is very important. And I think that everybody who is on medication, any type of medication really, should be explained properly and thoroughly how it actually works.
Thank you. This is so brilliant. I can't tell you. Thank you so much. Thank you. Really, it's wonderful. Can I ask a question, please? So when you started doing the exposure work, I guess the very generic question is, how did that feel? Were you worried about having to do the exposure? And how is that experience of, because we ask our patients, say, okay, this is what you need to do, we try to explain it, but what's the actual experience of being there and having to consider facing this fear and all that? So I don't know whether that makes sense.
Yeah, it's super difficult when at the time to kind of realize that that's actually what you have to do. You have to push yourself to get to where you want to be. And I don't think people are quite aware of the kind of nerves and the anxiety that develops and that comes with exposure work, even though it is very rewarding at the end when you get to the point where you want to be at. But when you are in that moment and you have to do the exposure task, and it's so challenging because you can't see forwards at all. So you just don't think that it's possible in any way that you're going to be able to do that. And then when you do, you get rewarded. So yeah.
How much? Sorry, go ahead, Kelly. So you were about to say something.
No, I just say it's that initial step. It's like I think it's quite like standing at the top of a diving board. Standing there and just nothing's happening. And it's that initial step that was torturous for Avella to take. The idea of even reducing or changing her makeup. I mean, Professor Veal said to her to try and change her makeup, take a sideways step, don't try and reduce it, just mix it up a little bit. If you normally use orange eyeshadow, use green, try something, a side step. And we took lots of those side steps, you did, and it kept her moving, even though it wasn't forwards. A sideways step is sometimes what it takes to get you moving forwards. So never kind of underestimate the importance of taking a sideways step on your recovery journey, I think.
Yeah, that's wonderful. And I presume it takes a lot of trust.
Yes.
To do this. Do you want to say something about that?
Well, it does take a lot of trust in that when I was doing it, the people, it took a lot of trust in the people around me, because the fear that they were gonna hate me, or the fear that they were gonna disown me because of what I looked like, was so real to me that I honestly thought that if I had changed my makeup, or if I wiped my makeup off and went outside, then something terrible would happen to me. So there is a lot of trust that you have to have in the people around you, that they do love you and that they do care about you. It doesn't matter what you look like. Yeah.
Yeah, that is wonderful. I think we should move on to have questions from the audience, if that's okay with you. Before we do that, and I see some hands that are up already, I wanted to read out a comment from the chat, and it is by my once tutor at the Maudsley, and one of my favorite people and psychiatrists in the world, Professor Isabel Heyman, and she says to you, Kelly and Avella, and massive congratulations, speaking and appearing on a Zoom call with 40+ people. That's maximum exposure.
Yeah, it is. It definitely is. Yeah. It's very handy that I can't see myself at the moment, so I'm not trying not to think about it. But yeah.
Well, thank you very much. So I'm sure I'm speaking on behalf of everybody here, saying that we're very grateful for that. I see that Professor Essie Widding has raised her hand.
So I've got a question for really both speakers and also Kelly and Evelina. Basically, I think what both the talks and your response to the talks has really highlighted is the sort of the complexities, that there isn't just one thing. You may need to have medication to be in a place where you can develop from CPT, and there are a number of kind of different issues that need to be addressed. And it suggests to me that we need work to understand what are the kind of the underlying issues, but also work to understand what are the sort of the social issues that might make, taking up interventions harder. So there is often, and I think you touched on this, there's often huge stigma associated with medication, which is silly, because you can change your brain chemistry by exercising. You can do it in all sorts of different ways. And I'd be just interested in the sort of the views of both the speakers on how you might address those sort of complexities, but also on the sort of views, sort of lived experience perspective. What do you think would be the sort of the helpful things to kind of educate people so that there isn't this sort of judgment, and so that we could do this work in a more complex way?
I was fighting for a long time for Avella to be properly medicated, and the resistance I had was the people prescribing it to her, and obviously getting that. So it wasn't, so Avella's point of view wasn't that she didn't want it or didn't understand it, although that was a factor further in. Initially getting it was very hard, and obviously getting her up to the correct dosage was really extremely difficult. It didn't really happen until we got with the Maudsley team. However, Avella was obviously resistant she was therapy resistant and resistant to take the medication once we actually got it, to the point where she would hide it in her mouth, spit it out. I would find them hoarded. Obviously, we're thinking that she's taking her medication, and Professor Veal was her prescribing psychiatrist at the time, because we were being treated privately. So yeah, I think that the understanding that knowledge is power. I've said this before, and obviously having it properly explained to her from a position of authority, that is a really big thing. It's not just something that she online or read from a leaflet. It's somebody that she trusts and understands that they are really knowledgeable about these things. To have somebody in that position say to her, just give it a go, just keep going with it, and and you'll see the benefits, but it won't be immediate, and you have to stick with the horrible side effects. That is something that was never explained to her. And obviously, the side effect, the emotional blunting that she had for the first 6 months of being on the 60 milligram of fluoxetine was immense. It was really awful to try and kind of nurse her through those first 6 months, where she just said she felt nothing at all, no joy, no sadness, nothing, just complete emotional blunting. But that has plateaued now, hasn't it?
Yeah. But also from from my perspective, when I was explained, when the medication was explained to me, it was that thought of, I really want to get better, but I really don't at the same time, because I don't want to wipe my makeup off. I don't want people to see me. So it was really difficult try and wrap your head around that. Once you start changing on the inside, then you can start making changes to the outside and your behaviors and what you do. Yeah.
That's very profound. Thank you so much. I don't know whether Georgina and Amy wanted to remark anything about that, maybe about the poverty of the field.
Yeah, I think Avella, you've pointed out something that lots of people with eating disorders also find very difficult, which is these messages about medication and what it may or may not do to you. And often the people I've worked with will say, you know, I've read that it causes huge weight gain and it does this and it does that. And that can be really frightening and can really put people off. And so I think, like you say, sort of, Kelly, hearing it from somebody that's worked with lots of actual people that have struggled with these difficulties and has that real clinical experience and knowledge can be really comforting. And we often say to people, you know, try it as an experiment. It may or may not help, and you can always stop taking it. But let's collect some data and see if it might help you to make more use of the psychotherapy, and might help you get a bit unstuck. So that's often a way that we would talk about it kind of within the multidisciplinary team with somebody. You're really pointing out as well, Kelly, something that's so important in eating disorders is it's not just the person, it's their loved ones, their family members supporting them and helping them with side effects and helping them to do the exposure work that we need alongside things like medication. Yeah.
Thank you. Georgina, I don't know whether this is a... Yeah,
I was just going to add, I completely echo what's been said already, but I also wanted to just, I suppose, reiterate, I think part of the solution is that we need better training for clinicians. So at the moment, BDD, for example, isn't part of the curriculum for CYP IAPT or for adult IAPT. Educational mental health practitioners, even clinical psychologists. So when I did my clinical training, I didn't have a single lecture on BDD. And I think that's crucial. It just needs to be recognized as a disorder that warrants being part of the curriculum for these different clinical training programs in order to improve detection and diagnosis, but also improve the quality of treatment and evidence-based treatment that we're offering. And I think there are aspects of BDD treatment that require kind of quite specialist tailoring. For example, with SSRIs, we know that most people with BDD require a higher level of SSRI and for a longer duration than you would do with depression. And so, yeah, I think part of the solution is around training, but obviously I think in the population more generally, the issue of stigma as well that we need to address.
and if I thank you very much, if I may add to this, it is absolutely surprising how little money is invested in researching BDD. I think Dr. Harrison mentioned that, but we have no good trial of the medication in young people. You know, what helped you? We would very much like to know how many people we could help like this, and we should trial it. And there is no trial, which is actually mind-boggling if you think about it. So we hope this will change with the work we do. Other questions from the audience, please. If we were all together live, I would ask people how many of them have seen someone with BDD, how experienced they are with the condition. I don't know whether there's anyone in the audience who would like to speak to that, or anything for that matter. Is there someone, am I right in hearing someone who wants to say something?
Hi,
Hi.
Argyris.
Hi.
Yeah, I'm head of undergraduate provision at the Institute of Education, and we have a student with body dysmorphia who we are trying to support with their studies. And so it's on my curiosity about the difficulty, because obviously that's not my area of expertise, that made me join today. So thanks, Kelly, and for joining us and explaining the condition. I was wondering if, as a young person, you had any advice. I'm not sure if you're still at school or at university or college or you're working. If you had any advice on how we, probably as academics, could help our students, or if there is any advice you could give that as personal tutors, as mentors, we could approach and help the students in a better way without making them, without being intrusive, without making them feel threatened, and of course stepping on the toes of their medication or any treatment they get. Thank you.
You speak first. I am not in education at the moment, but one thing I found while being in education was that the teachers and the kind of the people who weren't exactly aware what was going on for me at the time could say some things sometimes that would kind of trigger me, and I just feel like being cautious with your words, maybe asking them what you could do that would help them. Just I'm not really.
Yeah, it's like if you had a one-to-one with the student, just to find out what the triggers are, and obviously if he or she is doing some exposure work, it's best not to try and bring that into the classroom. Let them have their therapy separately and just support them. It's like, you know, exposure tasks are not best done in a classroom with other students when you're trying to get on with your work. So it's best just to ask them what their boundaries are, how they feel comfortable, whereabouts in the classroom, if it is a classroom, they would like to be seated. Avella, in the short time that she was at school and in her teenage years, liked to be sat at the back of the classroom. She didn't like people looking at the back of her head. She didn't like being observed. So she wanted to be back at the back of the classroom and to be able to participate in the, you know, the classroom environment, but from not a position where she could be seen. And it's really difficult. Everybody seems to want to comment on Avella's on how she looks. Everybody wants to say, "Oh, you're such a pretty girl. How can you be so ill?" And they say things like that to her, and it's been commonplace that she's heard that throughout her whole, her whole childhood, obviously, but also her adolescent years. Even though people knew that she had a body image disorder, the very first thing they would say is always that type of thing. And we believe that was kind of part of one of her triggers in adolescence, was that she had been put on such a pedestal as a child, that she just felt, it was unachievable to kind of carry on that way. So definitely communication is key if your student is able to receive that kind of information, but definitely on a one-to-one basis, nice and and just see what they would find difficult and what they would need. So they're the only person really that would be able to guide you with that.
That's wonderful. Thank you very much for also mentioning societal expectations or expectations from the environment and the role of development, which is crucial, of course. So thank you very much. We have only a few minutes left. I see Professor Fleury and Heyman who want to ask questions. I think Professor Fleury was first. So Irene, do you want to go first and ask your question?
Thank you very much, everyone. Thank you very much for this fantastic talk. I have two questions, but perhaps given the time, I will ask the first one to Georgina, if I may. So Georgina, from your epidemiological data, did you find any clear patterns with socioeconomic position? Were there any clear patterns, any clear socioeconomic positioning patterns in BDD?
That's a really good question. I haven't looked at that. I have looked at whether there is any relationship with ethnicity, and there isn't. I guess the the caveat with all of these analyses that I presented today is that the number of BDD cases is quite small, 63. So as I mentioned, we really want to, and we'd always planned to extend to analyse, I suppose, a version of sub-threshold BDD, so people with appearance concerns who don't quite meet the diagnostic criteria. And I think perhaps with that, we could look at those associations that you've mentioned. That would be really interesting. And to my knowledge, there hasn't been any research looking at that. In OCD, which is obviously conceptualized as closely related, we see prevalence pretty much stable across different ethnic and socioeconomic groups. So it'd be really interesting to see if that's the same in BDD.
Thank you. One last question, Isabel, quickly, because we have to make an announcement at the end as well.
Okay, I'll be really quick. Thanks, everybody, for a fantastic session. It's a question for Georgina as well, actually. It's a bit related, George, which was, I was wondering about population rate in ordinary, just in the general adolescence, about concerns regarding body appearance, that sort of sub-threshold group, and perhaps the role of social media and whether that's getting worse. And it would just be interesting to know what whether there's quite a big subgroup who are significantly, excessively concerned about appearance, spending a lot of time, a lot of money, lots of worry, but not meeting threshold, and whether there's anything preventative that could be done.
Yeah, that's a really good point. So I think it was about overall 8% of the sample who report excessive concerns about appearance that are distressing and impactful, but don't meet that threshold for BDD. I think for the adolescent girls, it was about 12%. And we don't know whether it's on the rise. It's a question that's very kind of relevant and really interesting. I've been looking at the literature, and there's actually very little research. There's some in eating disorders showing these kind of secular trends, but nothing in BDD specifically. We do have some social media use data in this sample, so we could look at the links, but I think generally the research so far suggests with that specifically, that there are very limited longitudinal studies and the effect sizes are really small, and that it's probably a very kind of complicated, nuanced association. So the data that we have in this sample is fairly crude, like frequency of social media use, and I think we need to drill down much more carefully into sort of what form of social media you're using, how you're using it, why you're using it. And we don't have those data at the moment.
Thanks you very much. Thank you all very, very much. I would like to thank Avella and her mother, Kelly, for being with us today and being so helpful, informative, and for teaching us so much, actually. Of course, Dr. Krebs and Dr. Harrison, all the people who asked questions in the audience. I would like to make an announcement as well, which is that we have a new clinic linked to the University Clinic in IAPT, headed by Dr. Krebs. I'm helping out there as well. And it is precisely about body dysmorphic disorder and related conditions here at UCL. So just so that people are aware. Thank you all very, very much.
Thank you.
Thank you. Thanks, everybody.
Thanks very much.